The trauma of a head injury also means that there is a high risk of cervical spinal cord injury, therefore the management of the cervical spine is critical. The cervical spine is immobilized until an injury is ruled out. If a rigid collar is unavailable, one person immobilizes the head while two others use a bedsheet and IV bags to hold the neck. The bags are secured in place with tape.
When we have a patient sustaining a trauma to the head and neck, we should always suspect cervical spine injury. So we should immobilize the cervical spine until we rule out that there is no spinal cord injury at the cervical level. To do so, ideally we should have a neck collar, a rigid neck collar, but if a rigid neck collar is not available, we have to use a bed sheet and IV bags to immobilize the neck. So to do this, we need 2 IV fluid bags, a bed sheet and a plaster. So we use the bed sheet, we spread the bed sheet while 2 people are preparing the bed sheet. We have to immobilize the neck and we have to be strict about it. So we need 3 people to do this. 1 who immobilizes the neck and 2 who prepares the bed sheet with the IV bags. We slowly elevate the neck and the head meticulously, and then we pass the bed sheet underneath the neck and the head, and we put back the head, and then we put the IV bags inside of the bed sheet and roll the IV bags so that we have a rigid type of immobilizer around the neck. So once we do this, we hold both sides of the bed sheet, and we have to make sure that we are the neck is not moving, and we apply a plaster across the chin and across the bed sheets laterally, and we also apply a plaster around the chest. And 1 more around the chest, that's around the upper part of the chest. So we leave this until we have cervical rigid neck collar, or until we rule out that there is no cervical spine injury to the patient.
Here is the protocol for neck immobilization when a collar is not available. 1. Hold the neck strictly immobilized. 2. Carefully elevate the neck and head without any manipulation to pass the bed sheet under the neck. 3. Wrap the IV fluid bag with the bed sheet on both sides. 4. Apply the rolled bed sheets strictly to the sides of the neck. 5. Apply tapes across the chin and on both sides of the neck. 6. Apply tapes on the upper shoulder and across the lower margin of the IV fluid. 2 people can apply a rigid neck collar. The neck collar has 2 parts. The posterior part is placed behind the neck, while the head is held strictly immobilized by the head clinician. Then the anterior portion is secured in place. The head can then be released.
In any patient who has a suspected spinal cord injury, a cervical spinal cord injury, neck collar should be applied. The neck collar should be rigid and it should be the appropriate size. We have the adult size and the pediatric size. For this mannequin, we are going to use an adult size cervical neck collar. For any patient who has a suspected cervical spinal cord injury, we should have two people to apply the cervical collar. So one should immobilize the neck strictly while the other applies the neck collar across the neck. We have to have a good traction of the neck and the head, and then at the same time we should elevate the head while our assistant puts the neck collar underneath the neck.
To apply a rigid collar, 2 people are needed: the head clinician who immobilizes the neck and the assistant who applies the neck collar. The neck is immobilized strictly while the collar is applied. The appropriate size of collar should be chosen and made sure it fits on the neck. The following video demonstrates the application of a neck collar to a child. The technique is similar to that of the adult. We should apply an appropriate size collar to a pediatrics patient.
For all pediatric patients who sustained trauma, we should suspect cervical spine injury, especially for those who had traumatic brain injury. We should immobilize the neck by using a neck collar. We should choose the appropriate size of the neck collar for pediatrics patients. To do this, we should have 2 people, one who is going to immobilize the neck while the other applies the neck collar. Always we should really be cautious and immobilize the neck strictly and apply traction and elevate the head very slowly, and while our colleague applies the collar just behind the neck.
Here is the protocol for the application of the rigid collar in a child. Skeletal traction prevents the progression of spinal cord injury by immobilizing the neck and also reducing fracture dislocations. Pictured here is a Gardner-Wells skull tongue. The video depicts closed reduction with Gardner-Wells tongue application. When we apply the skeletal traction, we should be mindful of the anatomic landmarks. The area of application should be cleaned with iodine. The pin sights for the tongs should be 2 to 3 finger breadths above the ear to avoid going into the temporalis muscle. We should use local anesthetics, lidocaine with adrenaline, to alleviate pain.
Okay, so we have got a patient with a subaxial spine fracture, and we are going to do external immobilization or closed reduction. And for that, what we use is a skeletal traction set or a skull traction set, and it has a trolley, and it has got pin at 2 sides. And also the other material we need is we have to clean the area of pin insertion, and we have to infiltrate the area with lidocaine. And after that, so those are the materials we use for. And the other thing is the back or the weight or the trolley. So depending on the level of fracture, the weight is determined based on the level of fracture, and we usually apply 2 to 3 pounds per level. And we have a weight, and we just put it here overhanged using the trolley. And so we will proceed with the demonstration. The first thing I have to do is I have to clean the environment or the area with the solution we have, and then after cleaning the area of pin insertion site, that is usually 2 finger breadths above the ear. So we usually place it in the neutral position, but sometimes depends on the type of fracture. We can go either anterior or posterior in order to have our proper reduction. But in our setup, we usually do in midline. So after cleaning, I will proceed with infiltration, local infiltration with lidocaine. So I already measured just 2 finger above the ear lobes, and I will infiltrate with Then I will just aspirate check first, then I will infiltrate our local solution, anesthetic solution, and I will do again on the same side, and using the same technique on contralateral side, then aspirate and then inject the local anesthetic. So then we will proceed with the traction. So here is our traction set. Then keeping the patient in neutral position, then at the insertion point we apply our skeletal traction in neutral position. So you can use like 40 to 60 pounds here, and depending on the age and the weight of the patient. After that, after it properly fits,
you tighten the knots then.
Yeah. Then we will apply our pre-measured weight, and then we usually use.
We usually use 5 pounds per level, right?
Yeah, we can go as maximum of 10 pounds.
So the weight should hang freely so that we get a good effect from the weight, so that the spine dislocation reduces effectively. So we just leave the weight hanging, and we see that it's tightly fixed on the skull, and then the weight is hanging freely. So we just take control x-rays to see whether the dislocation has reduced. If the dislocation doesn't show any reduction, we can increase the weight gradually. We should treat the patient. We should give the patient pain medications, as this is a painful procedure and the patient is laying flat on the bed for long. We should also give DVT prophylaxis and also prevent bed sore on this kind of patients.
Please demonstrate and video record neck immobilization. 1. Using a bedsheet and IV solution. 2. Adult rigid collar. 3. Child rigid collar. 4. Skeletal traction. Score your Pearl France out of 20. 5 for each of the 4 methods.